Hello, fellow dentists of San Mateo County Dental Society. I have the honor and privilege of interviewing our speaker for March 22nd, Dr. Todd Schoenbaum. He's agreed to do this interview tonight, even though he is on the streets in Japan. This is definitely his specialty, and I know that there's many questions that you guys have when it comes to restoring implants, such as screw retain versus cement retain, splinted versus unsplinted, what to cover the screws with, cotton tips versus Teflon tape, or anything else. I encourage you to come out on March 22nd. We're honored today to have Dr. Todd Schoenbaum join us, and we welcome him to our general membership meeting on March 22nd. This is actually our second attempt at this. The first time we tried when he was at UCLA, it didn't work out.
It's entirely limited to bolting things together, basically, for lack of a better term.
We had problems with the video, so this is take two. Also, we'd like to thank you because this is your third time joining us at the San Mateo County Dental Society.
Yeah.
Definitely.
Yeah, looking forward to coming back.
Yeah, you had a lot of great remarks from the comments that were made before from our members, and so we thought it'd be great to have you back out again. What can the members expect to have to listen to and to hear from you when you lecture on March 22nd?
So this time I was asked to speak about controversies in implant dentistry. So we will be looking at a number of topics that have kind of changed and evolved and maybe shifted, and some of the evidence maybe shows us better ways or easier ways or different ways to do things, and maybe with more predictability. A lot of that has really happened in recent years, but in the last 10 or 15 years or so, since we've had more and more robust internal connections. So on the restorative side, we've gotten a lot of advantages from that development, and a lot of the ways that we've approached things in the past maybe are shifting or changing. And so it's always a fun topic because it's controversial. So there's usually a little bit of discussion and a little bit of friendly argument back and forth or something, I might say. But so it's usually a fun. I enjoy this one. It gives us a chance to kind of look at the science of what's happened in the past 10 or 15 years and understand how that maybe adapts and affects our clinical practice.
Now, do you think an oral surgeon would benefit from this?
But yeah, I think it's relevant. Absolutely. I mean, relevant for any surgeon that likes to place and place implants, whether it's in the aesthetic zone or in the functional zone or wherever it may be. So it helps improve collaboration, helps improve what we can understand about what to expect. And I don't mean to be vague about the topics we'll be covering. We'll be looking at whether or not we should be splinting implants, what to do after torquing down implants, screw retained versus cement retained restorations for both partially edentulous and fully edentulous cases. So lots of interesting developments, especially relative to surgeons seeing increasing numbers of peri-implantitis. And what is that? How is it happening? And is there something that we can do on the surgical side to help prevent it? Is there something we can do on the restorative side to help prevent it and manage it? And the answer is not always just screw retain, as anyone who places or restores a lot of implants know.
Yeah, actually, being vague is probably good because it'll encourage them to come out to the meeting.
Yeah, I learn a lot from my surgical colleagues when I went to AMUS this year in Chicago, and I love it.
Now, the big debate, screw retain versus cement.
Yeah.
Do you have a preference towards one? I know there's probably different situations.
Well, we always have to be careful about what we prefer, right? Because my lab is not your lab, and my surgeon's not your surgeon, and my implants that we're using may be different than the ones that you're using. And so the passion on that issue comes from, understandably, the surgical side seeing well-placed, well-integrated implants being ruined by cement getting left behind. And so that's, a very, very real, serious issue with implant dentistry. And obviously a screw retained restoration prevents that. Screw retained restorations come with their own set of complications, significantly higher technical complications, porcelain failure in the older style PFMs, and increased incidence of loose screws, which seems a little counterintuitive considering it's the same screw and connection and torque setting. But that's a very long-winded answer. In the short answer, I probably do about 60% screw retained, and probably about 40% cement retained.
Now, with the cement crowns, obviously peri-implantitis is a big concern that people have. Is there a cement that's easier and less likely to cause that?
It's a great question. The answer is probably yes. The cement probably least likely to cause peri-implantitis is going to be any ZOE-based cement. Primarily, that would be temp bond or some derivative thereof. The problem, of course, with temp bond is that they tend to fall off. So, if you're in a practice where you're restoring, let's say, 100 implants a year or 200 implants a year, something like that, and those things all start falling off at 3 to 5 years, that's going to be a lot of time and energy in the practice, simply spent re-cementing things. Some companies have developed specific implant cements, and there's a whole slew of problems with most of those, to be quite honest. There was also a survey done, we'll talk about, that was done, it's getting a little old now, it was in 2013, but it's looking at what cements are used in residency programs across the country. So that's kind of interesting data point, and what we'll see is that there is no consensus, not by a long shot.
Do you recommend then for dentists to recall them afterwards, maybe a week or a month later?
Back a week after delivery is a great idea. Two primary reasons: screw retained or cement retained. In the cement retained scenario, yes, check for any sign of early inflammation, which should show up at the 1 week point at least, but not always. And if you find evidence of cement, anesthetize the patient and make sure you get in there and get rid of it. And we'll talk about techniques to minimize that chance. In short, if we had margin supragingival in every case, I could teach the first year dental students how to clean up that cement.
Sure.
That would be a no-brainer. The real problem is margin depth. And the other reason I like the patient to come back at 1 week is to check the occlusion. Sometimes they're getting tired of the appointment, or they're anesthetized, or they haven't functioned in their true functional envelope, and we have put them through sort of an artificial envelope of function to see if the occlusion's correct, but oftentimes they'll pick up something in the week after that they can let us know about. So, that may help prevent failures of the porcelain and or failures of too much stress to the bone leading to excessive bone loss or implant loss.
I'm imagining you're going to talk about it more in depth, but what goes into covering the screws is probably really important. Some people probably don't really consider it, but you've done some research to tell us.
Yeah, it's kind of a cool technique because it's one of those things that doesn't take any time, doesn't cost any money, and can really make a big difference for our patients and future clinicians, whether that's us or someone else that may have to re-access the screw. So long story short is anything but cotton is probably a good idea. Cotton's fine if it's going to be in there for a few weeks, but not for a few years. I'll show some of the work we've done on that and some anecdotal examples of what happens with cotton. And anybody that's had to retreat implants that have been in function for a while, had to pull out cotton, knows exactly what I'm talking about.
I have a colleague who told me that she's heard a lot about new types of crowns being placed on implants to potentially replace screw retain, cement retain, more along the lines of snapping on.
Right.
Are you familiar with that?
Yeah, so that's a development that actually came out of UCLA. It's a proprietary development that is, I think it's gotten its 510K clearance from the FDA, but it's not yet released to the market in America. It is in trial stages both in Los Angeles and I think a few sites in Asia. And that specific abutment goes by a few names: Smile Lock or Roto abutment. It's essentially a NiTi memory clip inside the crown that allows it to snap to a specialized abutment, and then that connection can be reversed with thermal energies.
I think I see a future topic for our membership. I might have to contact you again to hopefully get the information.
Well, I'll put you in touch with the people, that developed that.
Yeah. All right.
If you weren't into dentistry, what else would you be doing?
Yeah. Well, I race bikes, when I'm not working or spending time with my wife and our dogs. And if I had to make a living doing something else, I'd probably be machining something. Or I like parts, and I like making things, and I like, assembling things, which is why I found implant restoration so attractive. So maybe, one day I'll just have a big machine shop in the garage or something like that.
Surprised you don't have that already in your garage.
Yeah, my wife only lets me have so many hobbies, so we're running out of space.
All right. Well, thank you again for joining us, especially for having this interview. I know that we've gone through a lot to go back and forth to make this work. Technology is awesome, so thank you for allowing me to bother you or actually interrupt you on your vacation and your lecture that you're in Japan.
My pleasure. I appreciate all your hard work.
Yeah, and we will see you on March 22nd. Look forward to that. Have a safe trip back, and we'll see you soon.